Good morning, you guys. So I tease Junaid because I tell him that we had the hardest group and that the subject matter was really difficult. And it's because it's not that we don't all love emergency care systems, right? It's what we work and do and live in every day. It's rather when you try to define a research agenda around health systems, that becomes a very different thing, right? For those of us who are just kind of solely located in the clinical arena, and we like to think about these things, but we discovered in the midst of this that we had to do some definitional work. So if you guys hang with me for just a second, I'm going to introduce you to some of the topics that started to become the defining themes for where we've gone with the CLEER group. And so a lot of these things started right here in 2013 when we had the consensus conference that really tried to look at how do we start even laying out some of what these themes are in health systems research. And we've been unpacking that really for the last kind of 5 years, and the CLEER working group had to wrestle with some of these issues. And so like I said, we had to kind of get back to what the heck is health system research in the first place. And one of the things we discovered was, guess what, this field is really new. So health systems research was really just, the whole field was defined in 2010 in Montreux, Switzerland. By the way, we should advocate for that for next time we go to SAEM, right? Those guys had it right. They like convened health policy and system research in Switzerland. And so I wanted to go through just the definition of this for you guys. What this is, it really seeks to understand and improve how societies organize themselves in achieving the collective health goals, and then how those different actors intersect with policy and implementation processes. So there's that word again. By the way, this is going to be defining the next 10 years of the work that we're doing in bringing emergency care to low and middle income countries. By nature, it's interdisciplinary. You cannot do health systems research in your little silo of kind of emergency care. And it draws this comprehensive picture of how health systems respond and adapt to health policies and how those can shape and be shaped with health systems and the broader determinants of health. And so let's just talk about where this sits kind of intellectually and from a framework standpoint. So we get sub-individual level biomedical research. We all learned that in medical school, right? Individual level, certainly. Societal level, that kind of starts smelling a little bit like public health. So some of us have those degrees, right? And then if we're really pressed, we learn a little bit about social science. But look at where health policy and system research sit. Right here at that intersection. And so these are very different disciplines than just how do I run my emergency department and how does it work well in an LMIC? Because it has to do with these things of micro, meso, and macro. We'll get to those in a second. And here's how it sits with the rest of disciplines that often get brought up in the context of health system research. There's implementation science. So realize that it is a crucial portion of health system research, but it doesn't define it entirely. And so a lot of these things that we like to do, figuring out operations research, delivery science, implementation science, they sit within this larger domain. So what does it do? If we want to talk about emergency health system research, really it's two things. It's research on describing the system itself, like how does it actually work, right? I would argue that lots of times we don't really know. Do you guys know how the American healthcare system works with emergency care? I don't really, right? Like we have some thoughts about that, but how does that comprehensively as a system work together? And then it's also research on how do you change that system? How does it respond to certain forces? The defining role with this, right, is it's discriminated by the issues and the questions, not by the discipline itself. And so I just wanted to bring up a couple types of questions that we could imagine within the context of emergency health system research, right? Like, what are they, specifically in a certain country, and how do they operate? What needs to be done to strengthen those? How do you influence policy agendas to actually change the emergency health system? And how do you implement actions in order to achieve performance gains? And so really our goals are evaluation, there it is, right? And then evaluation of the policy process making as well. That's really how health policy and system research is defined. And so those were the issues that we were wrestling with as the CLEER group. And here's our old understanding. How many of you guys have seen this before? Building blocks of the health system, right? This is our old understanding. This is 2007 stuff, right? Everybody's business, that's how it was defined. And they said, okay, here are the 6 different domains, super useful. We used that in the 2013 consensus conference. We said, okay, we're going to analyze the health system in that way. And it has good stuff that this wants to do. When you put these things together, we want access, coverage, quality, right, for these goals and outcomes. But there's a problem with this model. It's a good one. It's simple, right? But there are a couple things you can probably already imagine. Number one, it doesn't tell you how those building blocks interact. It doesn't tell you, where are the people, by the way, in this? Where are our patients? How do they get to define the system in which they are functioning and seeking care? And then lastly, what about, we work in lots of places where there are parallel systems of care or non-traditional systems. Where are those in this model? And so there's been a lot of critique. I still think it's a good one to kind of wrestle with, and it's useful, and lots of people are citing that in the literature. But this is the other thing that we were working with the CLEER working group. So last things about emergency health system research, I just want to bring to the forefront of your mind to just know why I thought we had the hardest job. When we're talking, right, about, we talk about global health, we talk about global emergency care. When we think about that, right, we have to think about not only the local level, but how that moves through subnational, national, international level. And when we do that, there are two big things that we don't talk about in emergency care, but we have to think about in emergency health system research. There's that thing, again, I talked about, the micro, meso, and macro level. And I bring that forward to you guys because we're very comfortable, right, in the patient area about how kind of research is done with patients specifically. But what about as we move through the organizational and local level, that thing that we call the meso level in health systems research? And then what does it mean for the macro level and how global and national context actually ends up affecting the local level, right? These cross-translational concepts kind of like blow your mind when you're trying to think about, like, what am I actually going to study and what is that going to look like? The other thing is that I mentioned the building blocks to you guys. In health systems research, that's called the hardware, the system hardware, okay? The thing is that we can't just look at that, right? That's not the only thing that governs outcomes within health systems. There are some very substantial forces that I don't actually think we do a great job of measuring here with the system software. What about relationships and power? You guys deal with this every day when you have somebody who's quite vulnerable who comes into your institution, right? What about values and norms? How do ideas and interests actually affect patient outcomes? Okay, so now you guys are health policy and system research experts, okay? So those were the kind of themes that we really kind of dug into in order to get us moving forward with the CLEER questions. So we decided that after much discussion, there were really three big questions that right now that governed the space that we were in and where we were with the research agenda. And they are, so which components of emergency care have the greatest impact? So we know, like, you know, if somebody said, hey, come into we want you to consult and decide on which things you want to implement, say in Zambia, what are you going to say first? The pre-hospital system, facility-based care, task shifting? We talk about all these things, but if you had to put them together, which components have the biggest impact? Which mechanisms really effectively improve quality and expand access? And then how do we best match emergency care systems to the context? And that part's really important, right? It is not the American solution for a country that is not the US. Let's be super clear about that. But how do we do that? I think that is way less clear. So we've identified two big categories of research gaps in emergency health system research from the CLEER standpoint. One of those is in implementation. So Dr. Hardgarten mentioned that. We're going to harp on that. And the other one's in evaluation. And so just to dig into this a little bit, there's been a lot of questions about, this sounds kind of silly, but what do you implement? This kind of goes to the components. There actually was not a lot of agreement until recently with the WHO leading the charge on kind of like, what are the actual components of an emergency care system? We think we all know them, but we do need to come to consensus about what those are. So when we're talking about which components actually make a difference in outcomes, we need to be able to point to, like, it's these things that we all agree on make up an emergency care system. And then we ran into this other thing that was, what exactly is a health system intervention? Because as we started digging into the literature, what we found was we didn't actually have a very good idea about what that was. And so we did some definitional work about how that looked, and that those things had to include more than one building block within the WHO system, or one more type of service delivery location, such as a pre-hospital intervention and a facility-based intervention. Or it was something was implemented across a wide geographic region, so you're going to roll out triage across a whole country. That would be obviously a health system intervention. Then with regard to evaluation, here are some of the barriers recently, and we're going to show you some of the solutions we've come up with. The measurable indicators for the provision of emergency care in LMICs have been actually relatively few. Like if you had to point to what is like 10 indicators by which you are going to report to a funder? What might those be? We have not had a great consensus on that. Oops, sorry about that, guys. The other issue is those haven't really been accepted by policymakers per se and by providers. And so it's not only we don't have them, but we're not able to link them really well kind of with the people who are making decisions about health systems. And then we've had some recent progress, especially led by the WHO, as well as AFEM with their quality indicators, and then some of the WHO essential package of emergency care that's just recently been released. So in order to really identify, to really point at and provide a solution to, or at least one possible solution to, that evaluation piece, which is so important, right, for research. We've been working with this framework for emergency health system performance measures, and it has to do with the health system functions, and we put it into kind of like the inputs, process, outputs, outcome typology. So there are those building blocks, but here's how we think that they interact. So we talked about some of the limitations was we don't know how they interact. Here's one possible way that they might interact for emergency health systems. And then we've talked about, okay, what does emergency health system performance look like? How the heck would you measure that? And so here's one way of looking at this, and this is actually from a lot of synthesis of literature, of looking at effectiveness, equity, and efficiency, right, through all these outputs and outcomes impact. So this is very overwhelming when you look at it. And I just want to kind of just give you an idea of what this looks like in real time and how you would use this from a health systems research standpoint. Here's just one portion of a snapshot of a spreadsheet that includes how indicators are actually mapped to those things I just described in that big kind of that big health system framework. Here's what they look like. How are you going to measure availability of emergency care, right? You can look at things like emergency care specialists per 10,000 population. We've mapped to kind of where you can get that data. I want to point this out for Dr. Razak because I love this concept of his. Like, here's health status improvement. There is Dr. Razak's proposed mortality indicator for emergency care, which is a composite indicator of kind of how does the health system work? How are we going to measure that? Health improvement will be measured in this way. So I just put this forward to you guys to show you what we have been doing there. I want to thank the working group members because they've done a ton of work on this stuff. And thank you guys for your attention and time.